Okay, let's try to regroup. We're falling a little behind schedule, but I think we'll be okay. We've got some amazing speakers and panel discussions this afternoon. This should be a very rich discussion. And we're going to start out hearing from Dr. Roberto Tapia-Conyer, who's the Director General of the Carlos Slim Foundation. And Dr. Tapia-Conyer has really had an incredible record of leadership in the health of Mexico. He served with great distinction in the Ministry of Health for the country, and recently moved to the Carlos Slim Foundation, initially as heading the Carlos Slim Health Institute, and now leading all efforts at the foundation, which is doing important work in the area of health system strengthening in the country, instituting primary health care networks, but also showing some real leadership in the area of neglected tropical diseases, particularly Roberto's personal interest in dengue fever, and now embarking on some new initiatives with us at Baylor College of Medicine and Texas Children's Hospital in the area of Chagas disease. So we're absolutely thrilled to have him here and look forward to his comments.
Thank you, Peter. Well, good afternoon. This is fantastic. Thank you very much for the invitation to be here with you and to share some ideas around the concept of poverty and neglected tropical diseases in Mexico. Let me first say that I think that we are, how is this over here? I think we have to really define that the basis of a lot of what happens in our societies in Mexico, in any part of the world, it's linked to inequalities. And inequality is an example of based in poverty. And I like to take this part of what WHO defines poverty is. I was, I think, surprised for it to consider a disease. If you see it as something that has a cause and an effect, but at the same time you can see it as a risk factor. So it's this concept of a social condition that puts you at a special risk, at a different risk, and I think it's something that's why this morning I asked Peter if poverty is seen the same way in different parts of the world, and maybe is that we have a different concept depending on the ecosystem that we live every day. And I think that's part of it. But poverty also is an indicator of how human development has. And I think that we know that there's a number of thousands of millions of individuals that are at the poverty level, and I think that's very important. One of the areas in terms of gender, I think women are the ones that suffer more the consequences of poverty. And we know from also the UN that 70% of people living in poverty are women in special circumstances. And at the same time, that also moves into life expectancy, into the proportion of deaths, which is higher, obviously, in those impoverished communities. So there's no question that poverty is one of the most important determinants of poor health. And if we consider that, then we have to link the concept of poverty and health as a cycle. Because if we have a childhood, and childhood and nutrition determine educational level, which we know that happens, then we are going to have also a condition that education has a great impact at the end in the income level, and the income level together with parental education is going to determine health and nutrition. So the cycle is closed. And so it's very important to define how can we break that cycle and what are the interventions that can help to do that. And the expression of NTDs is an expression of those diseases that are within the cycle of nutrition, of educational capacity, of income level, and maybe in taking the concept of education, health, and employment is part maybe the solution to take people out of poverty. And that's really a very important concept around public policy. And so you have to be very careful of what we heard right now of investing from the legislator and the investments that from a social perspective, it really has a huge impact. And it comes into also politics. It comes into the context of political interest. It becomes in the context of even some areas would like to maintain population, let's say, under special conditions that they could handle their votes, they could handle their well-being. And so it's quite a complex, and it's not so easy to address. And that's why I think it's crucial to have this type of meetings in a building, in an area, in an institute that looks into public policy and to really start defining what can be done in a more systematic way and to have a voice around that. There's no question that poverty and inequality is in Mexico, and I'll show you some numbers. There's, in general, those that are, and there's more or less a very good understanding of people under poverty in Mexico. There's a special organization, independent organization, that does those measurements, and I feel very comfortable and very confident of what they are reporting. And there's no question that poverty is growing in Mexico. Inequalities are growing, and there's a need to let's say, to maintain the concept of why is that happening. And at the same time, you have to know where is that happening and what are the causes that are happening. And there's a profile. So if we link the indigenous communities and at the same time rural communities, and if you go down to women, and if you look at the unemployed or informally employed, and you look at their income, then you have a very specific profile of the poor of the poorest. So that's where public policy comes and says, what are the interventions? And there's a huge amount of investment and of resources going into these communities. You saw with Secretary Mercedes Juan mentioning a number of government programs that are intended towards that type of the community. And that's been there for more than 20 years with important progress. But even though there's been those interventions, there's still this inequality in Mexico. This is a very interesting map of the country, where you can see the three poorest states in the south part of Mexico, with Chiapas, Oaxaca, and Guerrero. And this is where you have let's say, one of the most difficult conditions in terms of migration process, that people coming from South America, but at the same time, you have the social conditions, and you have the less structured health services. You have, let's say, the human resources, even though they are totally committed, it's very difficult to bring highly qualified resources to the area because of the opportunities that they have. So you can have very good hospitals, very nice and very well equipped, and it's not easy to attract highly specialized or even to research. There's a huge research area over here in Tapachula for vector transmitted diseases, and it's not easy to maintain that type. So all these conditions remain, and then you can have also the link with other in brown, with not as in the numbers as these three states, but then you have a block here that really makes a country to have like a special emphasis in the southeast part of the country. But at the same time, this is a huge challenge for any health program that you have to really tailor by region and even by state and within a state. And this is also an issue that I think we have to consider when we're looking at interventions. What is going to be the emphasis and what's the threshold where you're going to begin to have the programs to be implemented? And this is a link with, for instance, with the previous map that I showed you, and the access to nourishment, to this high quality food. And so there's a straight relationship, maybe a bit different here with Tabasco, which is an oil state. Even though it has a high income, the income goes to the federal level, and it's not distributed equally in this part. And you can see that if you look at this comparison of lack of access to high quality nourishment, there's a more or less a parallel with poverty as in the previous map that I showed you. If we move, and this is just a data that just came out from the Institute of Health Metrics and Evaluation. Mexico is one of the 4 countries that has made a huge effort to drill down the burden of disease by state and by different causes. And I would invite you to visit the IHME Global Burden of Disease webpage and the capacity to do your own analysis around this. It's very easy to do it. And I took out these numbers, and I think it's astonishing at some point. And this is for 2013, the main risk factors for disease. And just look at the ones under 5. And there's still, in terms of proportion of attributable cases, malnutrition is 13.6%. It's higher, almost 50% higher than the non-exclusive breastfeeding. So even though there's been a huge progress around the nutritional status in the country, this is still a huge factor. But there's a combination here of not only malnutrition, it's also children that are getting overweight and excess calorie intake, which is happening in the country also. And it's not only anemia, but we'll look at that over here. Then the other aspect is how in a country the non-exclusive breastfeeding is also so important. But then you have over here iron deficiency, and then the intermediate breastfeeding, and at the same time you have the sanitary condition as an environment that affects the health consequences. So it's a very, I would say, for a country in Mexico to have in the under 5 this profile of attributable risk for cases, I think it is very, very important to consider. But if we move to the 5 to 14 years of age, then we see the iron deficiency, and now we are looking here at the problems which is linked and looking at the endocrinologist and internal medicine and consequences. It may be linked to the problem of some congenital problems, but at the same time consequences of high calorie and maybe some problems with diabetes. Remember that in Mexico there's hardly any diabetes type 1. So there's no question to consider. Right now there's no answer to this point. But look at the third position is access to clean water. So it's astonishing at some point where you still see this type of circumstances of lack of access of clean water and poor sanitation playing a role in a country that is really, I would say, in a condition that it would be unacceptable at some point. And now here, I would like to highlight no hand washing. It's interesting if we consider how conscious a community is of sanitary conditions in their community, but on their own person at the same time. So this is a very interesting table of the risk factors that are related with the production, with the generation of disease. So now looking at the specifics of the burden of NTDs in Mexico, numbers are important. Today we heard from the Minister Mercedes Juan a lot of the success stories and the challenging process. And let me tell you that a lot of that is by the encouragement of the local workers, let's say there's the political concept, there's the programmatic concept, but at the same time, the capacity for people to really do their job on the day. If today Mexico is considered onchocercosis free, is because it's been an amazing work for decades of the local people. So I think that's more in their benefit than a number of investments that has been done. And there's a very important challenge around Chagas, and as I will explain later, the dengue and the dengue hemorrhagic fever also. And a good work has been done around malaria, which it's the lowest number ever registered in the country. This is an interesting map where we could look at, for instance, the trypanosoma cruzi vector transmission in different parts of the country. And you can see that it's linked a lot to this process of also poverty and poor sanitary conditions, mostly in poor dwellings. So, but it's not only in those parts, and we're looking in areas like Cuernavaca, for instance, one hour from Mexico City, where you have weekend homes that are in this interaction between the poor dwellings and this high-quality housing, and the interaction as a vector transmission disease, it's really a way that social class interacts between one another. It's not that it's only on those that live in poor areas, but you also see it interacting with other socioeconomic classes. This is with dengue. It's, as you can see, well, Mexico has had history for the number of 4 serotypes, but there's also a very nice profile linked to the poverty conditions. So you have the Yucatan Peninsula, the Gulf Stream, and the Pacific Stream. This is a bit of a different, this is due to previously the serology in this part was very low, so you have a more naive community and you have higher incidence at this moment. And the same thing happens in Baja California, but I would emphasize the importance that this is the high prevalence of dengue in the country, and it's linked to poverty and poverty at the same time with the risk of developing dengue. So how to address NTDs? Well, first of all, I think as we have mentioned here today, the importance of really measuring the real burden of each NTD. And that has to be, and it's amazing to have just to learn that a bill is passed to have a sentinel system in this state, in Texas, and to have a very specific budget to do that. At the same time, when you're measuring, you need to consider to ensure access to the prevention and treatment. Even though in the case of Chagas, there's the drugs that are available, they are not accessible to everybody. It's a bureaucratic process that enables people to really have an effective intervention and drug treatment process. At the same time, it's crucial for a public policy standpoint to have an incentive and an incentive for a research and development agenda for diagnosis and drugs, and that's part of the the nice project that we have with Baylor College of Medicine in terms of developing the therapeutic Chagas vaccine. On the other hand, the training of health community workers into more thinking on a proactive process and control measures, and also to address the social determinants of neglected tropical diseases. So based on this, let me give you like a summary of a case study of taking these principles that I just mentioned and how can we address the innovation around dengue prevention and control. And these are the 4 areas that we feel that there's the opportunity to do really a change in the profile of what's happening in dengue in Mexico. On the epi-surveillance side, which is crucial, then on the development of human resources, the clinical management, and I'll touch some issues around the vaccine introduction. On the first part, in measuring the real magnitude, in terms of really knowing the burden of dengue and the cost, because it's always important to consider both elements. And based on studies done in Mexico by Undarraga and Don Shepard's team, this is very important numbers. Of those that we know that have been hospitalized, you have to add 2.3 cases per case that's been hospitalized because it's not registered, it's an underreporting process. And of every ambulatory case, there's 15 more cases. So if we take the cost of being treated at a hospital and you multiply that for 2.3 times, and the burden that has at the community, at the family level in terms of direct and indirect cost, and you multiply that figure for 15 times, it's a huge burden. And you can see that with the DALIS, which is a quite open number, but it's very significant. And at the end, the annual cost due to the diseases, and this is not looking at indirect cost, it's only direct cost, it can reach up to 328 million per year. So this is already a number that puts into the, let's say, into the pocket of how to do that and how to address the problem of dengue and the consequences that of any intervention. And it's very important to consider that dengue today, it's being handled the same as it has been handled for the last 40 years. Dengue is a disease where no innovation has been, there has been no innovation. We're still handling the same methods of control, which everything has shown that they could work much better than what we have seen. So looking at epi-surveillance, Mexico has quite a good surveillance system. It was matched a lot with CDC. We worked together with CDC to develop the Mexico surveillance system in general and specific with some around dengue and other vaccine preventable diseases. But today, it's, I think, feasible to consider the use of mobile technology for early warning. And we at the foundation, we are very engaged into this process. So we are developing warning systems for dengue cases that at the same time they can, let's say, interact with the formal surveillance system, and you can help through the community participation with a simplified surveillance system, and at the same time to make, let's say, the health worker, their work to be easier at some point, so that the data, even though it's not so, let's say, hard data as you would consider from a formal surveillance system or a sentinel system, you can spread out the word and you can have more information. And today, you can really support decision-making at the operational level. So the use of technologies and to use like the big data process, which every day becomes simpler in a let's say in a programmatic way, you can look more at the epi trends you can have the hair reference, and you can also do the alert messages to the entire by levels, so that you can have the resources to anticipate and even to control an outbreak. The other component is the clinical decision-making process. Dengue, even though it's a disease that it can be understood, when you have a patient in a hospital, you really don't know, you don't have anything to handle, only that you have to be looking at their evolution. And you have to be very careful with the liquids and how you handle the rehydration process, so that, there's no antibiotic, there's no antivirals, there's nothing that you can consider like a treatment kit that you can handle. So it's the capacity for clinicians to handle each patient. So what we're doing is also using technology to have an expert system that we call the dengue specialist, that really helps you at some point to handle the severe cases, and also to include more information that you can ask the patient, or you can go to the laboratory and to have a reference tool for a decision making and to make a differential diagnosis, now more with chikungunya and influenza. So this is a way that you can help increase the quality of health services, and that you don't rely solely on the experience of a physician or maybe intern that they are in a rural hospital treating dengue patients. So this is a standardized way to make sure that you have a quality of service and a quality of treatment, and you can really reduce the burden of severe cases. So this is an experience that it's been implemented in specific sites right now, and we are hoping to launch this in a couple of months. The other important piece of innovation around dengue is training. Here we have mentioned the importance of awareness around the physicians, nurses, the health workers, the community health workers. It's crucial to do a systematic training. Mexico doesn't have a continuing medical education platform. So what we did is we constructed online 24 hours asynchronic platform that it's available any place, and it's focused on a day-to-day operation with very practical contents. It's towards the generation of competency, the introduction of innovation. It's in Spanish, obviously, and it has been developed with national, international experts. And it has 3 levels: the basic course, then you have the intermediate, where you go into more details, and then you have more an advanced course. And this is very important, and people are really happy because they are really getting into the update of management and innovation. Then the other part is towards the introduction of dengue vaccine. I think dengue is been, there's about 4 vaccines out there in different stages. And there's one which has ended clinical trials, and now it's ready to be registered, and it's been considered to be licensed in Mexico and in many other countries in Asia and in Latin America. But 3 years ago, together with the Ministry of Health, we decided to consider the importance of having a proactive approach of preparedness when the vaccine was available. And this is a change in the normal process, because normally what we are used to in public service is that you start thinking of the introduction of vaccine when it has been introduced elsewhere, not in Mexico, that it has been registered in FDA, not in Mexico, and that has proven to have an impact elsewhere, not in Mexico. So today, new vaccines and new diseases that are really, let's say, linked to the possibility of having a vaccines are not in the interest of the US or Europe. And this is the case in the case of dengue. So dengue is not going to be registered in FDA. Dengue has to be analyzed within the concept of a vaccine against dengue, within the context of countries like Mexico and in Asia or Brazil. So you have to really be very careful of what's going on and what's the evolution of that vaccine. So that's how we started to develop a special group, and it was published in PLOS, that exercise, and now we are in the second phase of that, where it's an expert group where people from the Ministry of Health, the other health institutions, the states, the Mexican Society of Public Health, the academic universities, and we from the foundation, we are also linked to that. And to also have a link with the Partnership for Dengue Control, which is a worldwide organization made of experts that look at innovation in the areas of vector control of vaccines and diagnosis. So the team they worked around the episurveillance. What episurveillance do you need to have in place when a vaccine is going to be introduced? The cost analysis of the vaccine versus not doing anything or following the status quo, the implications at the operational level, the regulatory and legal part, the clinical impact, and also the communication strategy, because it's very important for the health provider and the community to understand what type of, and how a vaccine has to be understood when introduced. So this is a very proactive way of preparing a country to have everything in place to make the decision. And as it was mentioned this morning, Mexico is under the process right now of evaluating the vaccine to be registered in Mexico's FDA, COFEPRIS. At the same time, there's analysis of the different scenarios, taking where the highest impact could have the introduction of a vaccine, together with an integrated aspect. I think that the vaccine is not to solve the problem. It's going to come and be an additional tool into an integrated approach. And I think it's very important to see the perspective of a first vaccine, and maybe in a couple of years we'll have a second vaccine, and at the end of the next 5 or 8 years we'll have a cadre of alternatives for vaccination around dengue. So, but at the same time, this generates a new wave of innovation around dengue, and to consider that it's a disease that can be controlled and reduced. It has huge impact at the community levels. It's amazing the number of days that people spend without going to work, the consequences it has to the health system. So the profile of the vaccine, which is not the perfect vaccine, because at the end we have 4 diseases in one, but I think it's a huge advance, and we need to really consider to start using this new technology within the dengue arena. So this is, let's say, how to really put innovation into the NTD's agenda and to really shake the agenda so that we don't follow the status quo. So I want to end with this. What's the social role of private sector, of foundations? I think that we have a special participation in the acceleration and catalyzing innovation. Governments is very difficult because they are on the daily, let's say, agenda. They are really looking at whatever is happening today or maybe tomorrow, but not beyond that. And there you need a team, like a think tank, that really is looking at what's happening around the world and what are the initiatives that need to be in place, and to really move the agendas. I think that's a very important piece that we play. The other part is that we can generate of this, let's say, solutions around research and development. An example is what I mentioned with the Chagas vaccine. And also to have innovative platforms for training and to be low cost, very low cost, for those that are out in the field every day and that they can really have access to high-quality contents. And at the same time, to produce the evidence to follow on the generation of knowledge. And let me close with this thing that I'm truly convinced. I think that the value of public-private partnership is that it has to be translated into public policies in order to be sustainable. Otherwise, it's always nice and it's very, let's say, encouraging for any organization, a foundation, an NGO, whatever, to have a commitment. But at the end, you will never have enough resources to sustain a project. So you have to really make that happen and to be sustainable, to become public policy. And you have to really move all the pieces so that then it's sustainable and then you have a greater impact. One of the philosophies that we have of the foundation is that we like to always work together, but we're like a marriage, that we look at the details to get married, but at the same time we're looking at the details where maybe we wouldn't be married. And it's like the how do you enter the strategy and how do you have an exit strategy? And I think you have to really be conscious that that's a natural phenomenon. But at the same time, you want to maintain that and to be beyond your intervention, it has to go to public policy. And I think that the interaction between foundations or social sector and government and academia, it's a very good piece of advice of how to handle. And in the case of NTDs, I think that it raises awareness, it raises political commitment, and it brings more actors without a special agenda. I think that the problem here is that there's one agenda and everybody has to be part of it in terms of the benefit that can have in a social perspective. Thank you very much for your attention.
I want to take a couple of questions, but I also want to just give a brief summary of where we're at so far, because you wound up providing an amazing summary of the whole day, which I want to bring to light a couple of issues. Any questions in particular? So one of the things that I was really intrigued about is the fact that I saw some real similarities between the problems that we heard about neglected tropical diseases in Texas and with Mexico, but also some important differences as well. So one of the, do we have a microphone that I can hold? So one of the important, among the similarities is the fact that one major theme arose because of the similarities in the infectious diseases we're talking about. We heard from Christy, especially this overwhelming concern about vector-borne diseases in Texas, both arbovirus infections and from Chagas disease. And we heard basically the same theme coming out of Mexico as well. So I think we share, certain diseases, and I would add probably cysticercosis from what Rogelio said. But an important one theme that emerged is this is not so much a border issue, because if you look at where the diseases are, it's not so much at the border, northern border with Mexico, of Mexico. It's in the south. It's in southern Mexico, and same with Texas. So they're regional focus, regional foci, but it's not really so much a trans-border issue. And if people disagree with me, please speak up. There are also some important differences, because I think you emphasized the importance of underlying malnutrition, that I'm not sure we're seeing in Texas or not. I think that also the impact of iron deficiency anemia, which is something I hadn't really thought about before, but could be very important. Or also, I think an important emphasis, what you mentioned, was a rural emphasis, whereas of course, Texas is a highly urbanized population. Does anybody know what the percentage of Texas is urbanized, is an urbanized population? I know that number's out there, and it's certainly more than 50%. It's probably about 70, 80% urbanized.
Sure. Or even more.
What's that?
I'm guessing about 40, because Texas is still very rural.
Is it? Yes. Well, certainly not in the triangle around here, but once you get outside. But in terms of total numbers of people live in Texas, I thought it was highly urbanized. You also mentioned the needs that we face, and I think this is going to be an important general theme, measuring the burden of disease, including health economics, ensuring access to prevention and treatment, incentives for R&D, training health community workers, social determinants. I think these are all going to be critical elements for when we look at common themes between Texas and Mexico. But then you did something really fabulous, which I really liked, which was you took dengue as kind of a paradigmatic disease and went through what are the pieces that that really need to be covered, which include the investment in human capital, the clinical decision-making process, the looking at hospitalizations, cost, the training component, the public policies through public-private partnerships.
And the vaccine.
I would think that in the vaccine, I think, we could go through that with every major neglected disease that under consideration and how far we are and draw some gaps. I think that was really fabulous. I really appreciated that very much.
Yeah, thank you, Peter. I think this is very important. What the closing remarks that Peter has is that I think we have to set like the paradigm that the ideal components that we want for each one of these diseases and how far we are from that, and then to build up an agenda to reach that. And I think that's where resources can be oriented. You have your, let's say, your priorities, and you also handle your resources with the capacity to have a response and to do a lot of lobbying around that also. So I think it's a very academic and systematic way to address an agenda and to build up an agenda that can have different stages. So thank you very much.
Thank you.
Thanks.
Very much. Our next speaker is Sarah Marshall Murray from the End Fund, and hopefully she'll talk to us a little bit about this very innovative approach to mass drug treatment and some of the success stories with the End Fund. So Sarah.
Well, thanks, everyone. It's a great pleasure for me to be here today. This is not the typical group of individuals I get to speak to and have the pleasure of working with. I tend to be in audiences who don't know what neglected tropical disease stands for. So it's been a real treat to be here, hear the students, and then hear you all speaking today. Just quick show of hands, how many folks in the room are from Texas, so I have a better sense of the audience? Okay, how many folks are from Mexico? Washington, D.C.? Other. Okay, great, good. Okay, and I'm going to assume if I ask this question, almost all hands will go up, but I'm going to ask it anyway. How many people before today knew what NTD stood for? Okay, just to my point. Okay. How many people in 2015 made a gift to any nonprofit organization registered in the US, Mexico, London, somewhere, regardless of what it does? Can you raise them a little higher so everyone can see that? Okay. You guys are outliers, believe it or not, already, for many reasons, not just because of NTDs, but also because of your giving. So what I've been asked to talk about today is resource mobilization, which in my space is a weird terminology. We call it either giving, philanthropy, or investment. And as Peter, is this a click? There we go. As Peter was alluding to, the End Fund was born about 4 years ago now out of the London Declaration and some great work done at one of the many hats where Peter works and lives at Sept to recognize that there was a role for the private sector to play in this and a role for private philanthropy to play in this. And originally I had some slides in here about ODA and bilateral funding, which I think we've covered. They're kind of flat. The U.S. government is giving some great resources. DFID is another very engaged actor in this space. But they have their political interests, and as you can imagine, serving all of us is a tough job to do. But what's a space that could have the potential to grow, and private philanthropy is one of those locations. So today I'm going to try and focus a little bit on that and focus a little bit on what the End Fund is and our role in that. So this is normally the first slide I have to show. We're going to go right through these. The End Fund focuses on what we consider to be the big five, or the ones that disproportionately affect sub-Saharan Africa. So when trying to mobilize resources from the private sector and from individuals in general, you have about 30 seconds to get their attention. So starting with the frame of, there are these 17 diseases that are grouped together, and some of them are treated this way and some of them are treated that way. You've already lost your audience and you're not even on the second floor. So for us, we talk about the big five, and that they impact over 1.4 billion people around the world. And that for less than 50 cents a day, you could treat and control these diseases. Oversimplified for this audience, I know, but an important message for you if you're going out to raise resources. You might want to start there and then get into some of the more specifics. So again, the End Fund was brought into existence in 2012 because of the vision of folks like Peter Hotez and one of our founding board members, Legatum, who is a private equity bank based out of Dubai. You might say, what does a group of gentlemen in Dubai who raise capital for a living have to do with NTDs? But they read an article in The Guardian that talked about the efficacy of mass drug administration and the abilities to be able to treat large groups of individuals and be able to control these diseases across the continent of sub-Saharan Africa. They felt called by that efficacy message, but what really speaks to our mission and why they stayed engaged was that it's about people. And I think that's an important message that you'll hear from me for the rest of the presentation, is just how important people are in any story of philanthropy and raising resources. Your story, the story of the beneficiaries you're working with, the story of the scientists in your lab, the stories of the research, and the end game of where you're going, all very important to weave throughout anything you're talking about. So this is just, again, a little bit of the overall community that we work with. The End Fund can't do any of our work unless we are thinking about, reflecting on, getting feedback from, and communicating with everybody who's represented by these organizations in our community. It means we do an awful lot of talking. Means we do an awful lot of collaborating. But in the end, we believe that it allows us to be able to speak to anyone who might have an interest in getting involved in NTDs because they think of it as a huge economic potential gain for sub-Saharan Africa. They think of it as a human rights frame because they don't believe in the disfigurement and disabilities that it creates. They think of it as a nutritional or a public health intervention. Or what we're finding increasingly powerful amongst private philanthropists is the value it plays in the conversation about education. So many different things have been applied, so many different things have been tried. However, if all of us were sitting in this room today had intestinal worms when we were younger, we probably wouldn't have had the brain capacity to sit and learn and study the way we currently are, and we're able to today. I'm actually quite impressed that we're all still sitting still and listening after 2 days worth of lectures. So, I often take this slide out, but I think for this group, I think it's an important thing to spend a fair amount of time on, and which is the values that we at the End Fund try and live by, that we hope permeate through anyone who's working in the field of neglected tropical diseases. We heard a little bit yesterday from some of the medical students, which I thought was fantastic, some of the public health students, of this question of, we're not being educated about this because we're in a U.S. medical system and we're being taught about U.S. medical issues. I really hope that can change with this generation if that's true, because I would hope that we all recognize that we're all human beings on this planet together who just happen to have been born into a U.S. system instead of born into another country's system. And I hope that what we've learned from Ebola and other things is just how interconnected we all are in this world. And if we wait till those interconnections cause us pain or cause us suffering, we're missing a moment in time to be a part of our community. So servant leadership is hugely important to us at the End Fund, and we hope important to everyone in this room. Results in efficiency, we spoke a little bit about, which is why our frame of MDA is so important, and we'll talk a little bit about that in diving into a couple of our examples. Excellence in stewardship, again, we represent philanthropists. We also deploy resources to beneficiaries who are looking to us to be their partners and be treated with the same ethics that we would treat our donors. So it's a hugely important part of our work and why we do what we do. And the joy and transformational power of giving. I was thrilled to see how many hands were raised, so you know how important it is to give. There's an African saying, Ubuntu, I give because you are. We're all a part of a global work, and the more you give, the more you get out of life. So part of why I believe the End Fund has graciously been offered this prime speaking role after lunch to talk is to speak a little bit about integrated MDA and the efficacy of that giving and how important it is to the next sort of quote unquote, I'll say innovation. I feel like the word has been said a lot, but the reality is the MDA is not that innovative. It's just applying a lot of smarts to maximize and effectively use resources from those who have the appetite to join us. So this is an example of one of 3 projects I'll quickly run through at the End Fund, which we think about when we're designing and working and finding partners. This one covers 4 out of the 5 diseases. The only reason why in Inequality state we don't cover trachoma is because it's not present. It is the cost per treatment is 40 cents instead of the 50 cents because of the design. But you can see from our desire to be transparent about where those resources are going that a lot of this is going to be about communications and being able to talk to both those who are being trained on how to deliver mass drug administrations as well as mothers who are your number one advocate for not only taking that pill on the day, but also making sure that their children learn how to use proper sanitation, hygiene practices, and ensure that we aren't continuing this cycle inevitably. But you know, a design of less than $1 million can treat over 2.4 million people. It's a pretty impressive ROI that sells very well in the finance space, as you might be able to imagine. So this is the head story that the End Fund often talks about, the efficacy, the efficiency. There's also the heart story. And when you're dealing with philanthropy and trying to motivate individuals to participate and engage, don't forget that we're human beings who are complex and have more than just a head. We have a heart. Mali is a great example. USAID in 2012 had to quickly remove themselves from a program they had been running for 3.5 years because of a coup. All of us as US taxpayers totally understand that, get it, understand why we wouldn't want to support a dictator. The heart, however, both of those USAID employees who had been working very hard, as well as all the beneficiaries who had been receiving treatment for 3 years, said, this is a tragedy. We will lose all of the progress, all that we've made. Isn't there something we can do? After many conversations, the End Fund went on a mission to find resources, deployed the resources to keep the program up and running for the last 2 years, and then passed it back over to USAID successfully at the end of 2014. Instead of starting back again at ground zero and starting the program over again in 2015 when USAID could enter because of obvious and good political reasons, it made sense for an actor like the private sector, who can be risk averse as well as innovative, to step in and keep continuity. So this is a great example of one of the ways the End Fund has had impact. Ethiopia is another great way. I share this photo because many folks don't often focus on young men when they're giving presentations. And Stephen is an interesting character who I've met in Ethiopia now 2 years. I've seen him receive MDA 2 years in a row now. He was named Stephen because his parents are huge Manchester United fans, and they love Steven Gerrard. He talked about this prolifically with me for a very long time and about his hopes of someday playing soccer professionally. I'm still American, so I'm still going to call it soccer. His mother has lost 4 other children. Stephen is a huge hope for her about what's possible. Rather than focusing on the 4 children she's lost, she focuses on the one she has. For a mother, every time I tell this story, every time I think about it, I can't help but tear up a little bit at the idea of how many mothers have had to make those choices about whether or not they focus on one or they focus on all, and how healthy. So a commitment made between the End Fund, SIF, the Children's Investment Fund, which is based in the UK, the Ministry of Health in Ethiopia, and two implementing partners, Evidence Actions and Deworm the World's partner, SCI, joined together to help the Ministry of Health own and launch a deworming program that will treat 20 million children at the end of next year. It's a huge undertaking. It requires a lot of coordination. It's definitely not for the faint at heart, but the idea that at the end of 2 years worth of work together, not only will the federal ministry have the staff and the capacity to be able to be the chief coordinator of this program, but then by the end of 7 years, be able to take it on fully and be able to resource it fully. It's the world we hope we're all trying to get towards. So just a quick snapshot of what the End Fund has accomplished in our first 3 years through our collaborations and our partnerships. We're currently engaged in 15 countries. By the end of this year, we will have trained over 300,000 community healthcare workers. Beneficiaries, we're looking at around between 150 and 175, depending on some projects that were still under evaluation and consideration this year, and the benefits of over 220 million in mapping, so we know where the disease burden and issues are. The good news is, through the efforts of organizations like USAID, DFID, the endemic countries, the End Fund, last year treated 833 million people. That's up from the last 2 years drastically. We still have little over a third more to go. But the good news is that unlike many global health public interventions going on right now, when we go out to try to sell this to individuals and explain why it's important for them to join, we're at an advantage because we have a huge amount of resources already donated from the private sector. The drug donations program is by far and away the largest public-private partnership that exists in modern history. It isn't talked about that way. We don't think about it enough that way, but it is by far and away one of the largest interventions in our time. It would be a shame for us to miss this moment and opportunity to take advantage of that. I can't tell you how many times I sit across the aisle from a pharmaceutical rep, and instead of being able to just say to them, thank you, and because of all the work you've done, this many children are being reached, I sit across from them and I say, I'm sorry, we haven't been able to utilize all the resources that you and your company have provided this year. And that's a real situation of where we are, and we'll get to that in a second. In order for us to treat and control the diseases and reach the 2020 target set by the World Health Organization, we would need to scale quite a bit from where we are. We're making great progress, but as you can see, the required trajectory require us to do quite a bit more in the next 2 years. The nice news is that in addition to the international resource commitments that have been made, we're seeing more and more endemic countries starting to have lines within their budgets. And when I'm talking about endemic, I am speaking mostly of sub-Saharan Africa. There is quite a bit of commitment in Latin America already on the budget line items, but where we hadn't seen anything in pre-2006 was in sub-Saharan Africa, where there weren't even NTD plans yet in place as part of the Ministries of Health budgets, thinkings, planning. So what does the End Fund's role in the modern movement of MDA, PCT treatment look like? I thought this slide is one I often use to give just a snapshot of how recent the story is, and for us to not lose focus and discipline on the idea that this is still a very modern story. 2005 is just when the Bill and Melinda Gates Foundation started to think about this in an integrated rapid diagnostic package approach. USAID got into the mix just a year later in how they thought about integration. DFID a few years later, and then the London Declaration came along and the groundswell. Peter and his colleagues were ahead of their time in recognizing that we needed a collective name before a collective treatment could possibly happen. The end fund being born out of this need meant that we already had some momentum behind us and a lot of supporters who wanted to see us succeed, which has certainly been very helpful in making sure that we can continue that momentum. But 3 years in, we're already 10% of the market share. If you go to any Fortune 500 company and you tell them that factoid, their ears perk up. It's very rare that you go from non-existence to 10% of a market share in any other business, in any other frame. It says that there's a huge gap to be filled, and it says that there's a huge desire. And the nice thing is that now gives us the opportunity to go out and advocate on behalf of those philanthropists that the private donors in this universe have a role to play, and this isn't just a bilateral game. So the reason why I shared this slide is to point out to the idea of what's possible from few. So this is just a sense of the end fund's trajectory. Since I joined at the beginning of 2013, we grew from having around 60 committed individuals, companies who partnered, to now around 683, where we currently are in 2015. That makes up $56 million in resources that have been invested into the end fund's portfolio. That allowed us to leverage over $250 million worth of donated medications to ensure that those get into the hands of those who need them most. The pills distributed by the end of this year look like they'll be over the 200 million treatments distributed through resources that we provided. It just shows you what's possible if we can amplify what we're doing and get more people involved and engaged. In this room, we probably have around 100, 120 people, give or take. If every single person in this room made a commitment to an organization that was working on NTDs, you can imagine the ripple effect, and so on and so on and so forth. I mean, I'm certainly encouraged by the work that my colleagues at the Global Network are doing to get the next generation of young people engaged and involved. But I think we'd be mistaken to say that the only way to get involved is to just be aware. I think that's selling all of ourselves short. Last year, Americans spent over $100 per person on candy. If every American spent $100 on any disease outside of their insurance covered outside, the world would be more like the place we all care about and want to be, and our public health system would be stronger for it. So with that, I will stop, because I think that that's a good frame of just who the End Fund is and what we've accomplished. And I'd like to turn over to you to ask questions about how we can help you learn how to resource mobilize.
Questions? Yes.
I was hoping you could comment on the measurement and evaluation of the investment of the End Fund in MDA and the willingness of the End Fund to kind of share that data with outside researchers.
Let me make sure I understand your question. Want to repeat it for me one more time?
I was just curious about kind of the measurement and evaluation aspect, kind of beyond the number of treatments given, and kind of the willingness to share that data with outside researchers to kind of aid in that evaluation aspect.
Sure. So we do share our data as we collect it, because we are funding other entities. We think of ourselves as a portfolio. So we take very much a private mindset like that. So we can splice and dice, like we did Inequality State, what we've done and where the money has gone. When we think about the results, we have some that are high performing and others that are low performing. One of our commitments towards that transparency was we were approached this past year by GiveWell, which show of hands, how many people know who GiveWell is, what GiveWell is? So it's a platform out in California to try and evaluate charities. Two charities that work in the deworming space, Evidence Action and SCI, have already been evaluated as stellar charities of theirs. And we're putting ourselves through that microcosm. So if you want to get a lot of data that's already public sourced, you can go to their website, because they have a lot of information on the End Fund that's already public. You can, of course, check out our website, but if you're not finding what you need, you can always reach out to me. So we are definitely open to it. But we're also 3 years in. So therein lies a little bit of the conundrum, in that our efficacy yet of our theory of investing in MDA is only able to be really analyzed for Rwanda and Burundi right now because those were our pilot countries. We started working on those through Legatum back in 2007. So we've had enough of a long tail to be able to say, what were the rates, where are we, and be able to give you any data to look at.
Dr. Tapia.
If I understand, please, for great presentation, but the end fund comes in as a consequence of Gates, USAID, DFID. Do you coordinate everything, or it's only the proportion of in the graph that I think there?
Yeah, so this is me trying to illuminate to what has been the story up until our existence about where funding has come from. It's been mostly, the Bill and Melinda Gates Foundation is a little bit of an outlier. They act and oftentimes much like a bilateral agency in giving in spaces, but private philanthropy was just nascent before 2012. So this graph was simply to point out that as the end fund grows, we're a larger and larger source of funding in the space.
And you do, let's say, your model, is it being considered by the other funding organizations?
Yeah, we certainly work in close collaboration between the other funders. Yeah, I hope I didn't gloss over this too quickly, how important this is for us, that we believe very strongly that this is an important, every single one of the entities in here is a stakeholder to us. And so we definitely coordinate quite a bit. I spent a lot of time in Seattle, Washington, D.C., Atlanta, London, talking to colleagues about where their priorities are and making sure we're in alignment with one another.
So, yes.
Yes. First off, let me say that your webpage is wonderful.
Oh, thank you.
That's one. But I wanted to ask, you mentioned low performing results. So is there any lessons learned, quick lessons learned that you can share right now about what you learned from that?
Sure. I think the naive question is, many people think if you have resources, it's easy to go out and deploy them. It's actually much harder to deploy resources than it is to raise it, in my very humble opinion. I've been on both sides of the equation, and I actually think it's easier to hear no when you're raising. We expect to be told no when you're on the nonprofit side and you're asking somebody to give you resources. But when you're told no for somebody you want to be involved in solving the problem and helping, it's a lot harder to hear. So probably for me, the biggest is our having to leave CAR. The political risks and the risk on the ground, even though the population is in desperate need of treatment and of help, is probably one of our biggest disappointments for the end fund. But we did a risk analysis of being able to properly do a program and decided not to. Most of the times where the end fund has not done work has been because we don't see ourselves as being the best placed actor. So we didn't enter into Haiti. We have a strong brand recognition in sub-Saharan Africa, so and our work there, and there are other actors who know Haiti much better than we do. We have moved into India and Yemen. We saw a lot of synergy between the way Nigeria is developing its public health systems and India, and there's a lot of cross-learnings. But we've only done that in locations where the state governance was strong and involved, and there was already technical expertise and other donors involved. So only in Bihar and Rajasthan have we worked in India. Is that?
So stay up here. I want to present you with a problem.
I love Peter.
So one of the reasons we got NTD funds mobilized in the U.S. government is, it took me a while to learn this, but so much goes on between the White House Office of Science and Technology Policy and OMB, Office of Management and Budget. And those two got into a room, decided they were going to put up the first $15 million for NTDs in 2005, and that moved thing. Then it goes through a more formal process and goes through the Congress. So when I wrote the paper, the Plus NTDs paper about NTDs in the U.S., I thought, wow, people are really going to get interested in this. So I went back to my old buddies at the White House Office of Science and Technology Policy and OMB, and told them the story. And then I told them I want President Obama to host a high-level summit on NTDs in the U.S., just like he did with climate change and infection and everything else. and thought this was going to be a slam dunk. And they said to me, well, Peter, thanks for the thought, but last time you went to us about neglected tropical diseases, you told us this great story that we could do something with a package of pills for 50 cents a person per year. Now you're telling us we got to do active surveillance, we've got to do studies to look at modes of transmission, what the links are with poverty, we don't have the diagnostics in place. This is too complicated. You gave us a quick fix for NTDs, and now you're telling us when it comes to things like dengue and Chagas disease and everything else, you got to do all these things. There's no victory here for the White House. So
the question is, how do I get a victory for our friends at the White House? This is why I left DC, Peter.
So I blew my chance. Well, I blew my chance. I could always go back to them, but I can't give them.
Yeah.
I can't talk to them like I talk to them about NTDs and what can we do with them?
Yeah.
You can think about it.
No. It's a great question, and it's an important question, and that's why I pulled back up this slide. I mean, Peter's work is with the U.S. government is super important. You'll see the blip in 2014. That was a drop. 20 million got taken out of USAID's work in PCT in 2014, and it was tough. I think the challenge we run into with being reliant on bilateral donors exclusively, and particularly government funding, is just, as you alluded to, is the competing demands and the changing priorities and the needs to focus in on other things. I mean, unfortunately, we are living in a time where everyone's attention span is less than 30 seconds. I've already lost a couple people in this audience in the 30 minutes I've been speaking. And I think I'm interesting, and I've lost people. So recognizing that you might lose them, keeping them focused, and reminding them of the successes. We talked for maybe a blip this morning with the Secretary about Mexico's success in eliminating river blindness. We didn't stand up and clap for her. We didn't stand up and clap for the Mexican people. We didn't stand up and cheer. Nobody's thrown a party. We barely got a press release. We're about to do that in 9 countries in sub-Saharan Africa where the ministry's budgets are less than probably what it costs to build this building. We just don't celebrate our successes enough. So then we go to the White House and we go to our friends at OMB and we put our hand out and we want more money from them, but we don't give them the chance to be a part of that celebration. You briefly mentioned USAID is about to treat this year their billionth treatment. That's huge. That's a big deal. But the American people somehow haven't figured out and been able to be a part of that celebration. So my quick and dirty answer would be help them to celebrate the successes and get in front of the successes first. And maybe when we go back to them and ask them to do more, they'll be more open-minded to it.
Clearly, the other reason we got NTDs, other than giving them a quick fix, was they were still basking in the glow of PEPFAR.
Yeah.
They were still.
It was a legacy,
they were
right?
Really very self-congratulatory, very excited, and appropriately so. It was a great program, and now we gave them something to build on. So.
And you have to recognize people's different competing priorities for their legacy. Meet people where they are when you're asking them to do something for you. So where's the Obama administration right now? What are they thinking about as his legacy? And his predecessor's legacy was PEPFAR, so he just may not be excited to jump into the global health space as his legacy right now. So.
Well, we're a bit over time. Let's go on. Thank you so much.
Thank you.